Hey there, it's Dr. Sarah here. Today on the She Found Motherhood podcast, we're taking a deep dive into a very commonly requested topic, hypertensive disorders of pregnancy. We'll talk about the diagnosis, the different types, what you can do to prevent your risk, and how we typically manage it. We'll get into all this exciting stuff right after this quick message. Welcome to the She Found Motherhood podcast. We are Doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
So let's get into it. What are hypertensive disorders in pregnancy? Really, this is just a catch-all phrase for all the different disorders in pregnancy that are associated with high blood pressure. There are basically 4 major types of hypertensive disorders that can occur in pregnant people. These include Preeclampsia, Eclampsia, and HELP syndrome. HELP syndrome stands for Hemolysis, elevated liver enzymes, and low platelets. Gestational hypertension, chronic hypertension, and preeclampsia superimposed on chronic hypertension. So we'll go on to talk about each one in more detail in a little bit. But first, we thought it might be important to explain to you why we should talk about this in the first place. Believe it or not, hypertensive disorders are a leading cause of direct maternal death. Women who have had preeclampsia and gestational hypertension are more likely to develop cardiovascular disease, chronic kidney disease, diabetes, and metabolic syndrome later in life. Hypertensive disorders in pregnancy can also impact the developing fetus. Severe disorders are associated with a risk of placental abruption, spontaneous pre-labor rupture of membranes, small for gestational age babies, and stillbirth. Chronic hypertension is also associated with an increased risk of congenital malformations in the newborn. So with that positive attitude, let's dive in. Let's start with chronic hypertension, which is also sometimes referred to as pre-existing hypertension. So chronic hypertension is defined as hypertension or high blood pressure that is present prior to pregnancy or is present on at least 2 occasions before the 20th week of gestation or persists longer than 12 weeks postpartum. This helps us differentiate chronic hypertension or pre-existing hypertension from gestational hypertension. If it starts early in pregnancy before the 20th week, then it's not preeclampsia. Now, pre-existing hypertension or high blood pressure can be primary, meaning we really don't have a specific reason for it, or secondary to an underlying disease. Now, a very common example would be chronic kidney disease that results in high blood pressure. Now, don't worry, we're not going to get into the nitty-gritty specifics of how you diagnose high blood pressure, but generally speaking, it would be diagnosed if you consistently had blood pressure readings with the systolic, or the top number, higher than 140, and or the diastolic, the bottom number, higher than 90. What's important to know about chronic or pre-existing hypertension is that up to 20% of individuals with chronic hypertension will go on to develop preeclampsia compared to only about 1% of the general pregnant population. So it's really important for us to be aware of pregnant people with pre-existing high blood pressure and monitor them closely throughout the pregnancy. Now, if you do have pre-existing or chronic high blood pressure, this would be a really great reason to chat with a provider before becoming pregnant, as there are certain blood pressure medications that are considered safe in pregnancy and others that we would want to discontinue before conception, as they can cause fetal abnormalities. Preconception counseling is valuable for optimizing blood pressure control with medications that are safe to use during pregnancy, and for initiating the administration of ASA, or baby aspirin, for risk reduction. We know that individuals with pre-existing high blood pressure are at a higher risk of developing preeclampsia. So this is a population where we would recommend starting on ASA, or baby aspirin, to reduce your risk of developing preeclampsia. We'll talk a bit more about that later on in the podcast and why we recommend this. So that's pre-existing or chronic hypertension. Now let's talk about gestational hypertension. So gestational hypertension is essentially high blood pressure that develops in pregnancy after 20 weeks, but is not associated with any worrisome features. otherwise referred to in our medical language as adverse features, that we see with preeclampsia. So between about 10 to 25 of pregnant people with gestational hypertension may ultimately develop signs and symptoms of preeclampsia. Gestational hypertension usually resolves by 12 weeks postpartum. If your high blood pressure persists beyond 12 weeks postpartum, the diagnosis is typically revised to chronic or pre-existing hypertension that was masked by the physiologic decrease in blood pressure that occurs in early pregnancy. Now, onto the complex stuff: preeclampsia, eclampsia, and HELLP syndrome. So preeclampsia, fortunately, is not a very common condition, affecting on average 1 to 2% of pregnancies, but it can have serious implications for both mom and baby, so we'll discuss it in detail today. Preeclampsia refers to the onset of high blood pressure associated with organ damage, including the kidneys, the liver, etc. And it typically develops after 20 weeks of gestation in a patient who previously had normal blood pressures. The organ damage is typically assessed by looking for abnormalities on blood work and for protein spilling into the urine. Now, the marker of protein in the urine may seem strange, but it's significant. Protein in your urine due to preeclampsia is a result of damage caused by the high blood pressure on the delicate blood vessels in these important organs, specifically the kidney. Now, we can also further classify preeclampsia based on when in pregnancy it starts. Early onset preeclampsia typically begins before 34 weeks, whereas late onset typically begins after 34 weeks. And believe it or not, it can also develop postpartum. Now, eclampsia refers to the occurrence of a grand mal or generalized tonic-clonic seizure in a woman with preeclampsia in the absence of other neurologic conditions that could account for the seizure. In other words, the seizure is caused by the severely elevated blood pressure and not by an otherwise underlying brain disorder like epilepsy, infection, etc. Now, although the numbers of pregnant people who develop these disorders aren't extremely high, it's estimated that the global incidence of preeclampsia ranges from 1% to 5.6%, while the incidence of eclampsia is even lower, ranging between 0.1% to 2.9%. These can have significant impacts on maternal and fetal health, both in the short and long term, so we need to be aware of these and treat according to guidelines. Then there's HELLP syndrome, hemolysis, elevated liver enzymes, and low platelets. This syndrome is named after the laboratory changes we see in pregnant people who develop this disorder. HELLP syndrome is thought to be a subtype of preeclampsia with severe features in which hemolysis, so breakdown of blood cells, elevated liver enzymes, and low platelets are the predominant features rather than high blood pressure or central nervous system and kidney dysfunction, although the latter can occur. Most people who develop HELLP syndrome, but not all, have high blood pressure. So somewhere between 82 to 88% of people will have high blood pressure as well. And they also typically have protein spilling into the urine. Anywhere from 86 to 100% of people will have this. Now, it's important to understand that there's never absolutes in medicine, really. There are the rare patients who have neither high blood pressure nor the protein in the urine. So you may see some discussion out there arguing that it may be a disorder separate from preeclampsia, but for the consideration of our discussion, we're going to include it in this category. So now that we've gone over the basic types, let's talk about what causes gestational hypertension and preeclampsia. Believe it or not, the mechanism is still not very well understood. It's thought to involve both maternal and fetal placental factors. Without getting too much into the medical jargon, it's thought that early on in the development of the placenta, the blood vessels that implant for some reason don't develop and evolve properly. Now, I have an analogy that might help you understand and it might not. So the way I describe it is, picture a garden bed and the flowers are the fetus that you want to grow. And the garden hose, watering those gardens, is the placenta and the umbilical cord. Now, with preeclampsia or gestational hypertension, what we're seeing is increasing pressures through those vessels. So picture someone stepping down on that garden hose. The water doesn't flow as well, so you have to turn up that tap to continue to water the flowers. And so that's what your body is doing in a sense. It's turning up the tap or the pressure in your blood vessels to continue to water your placenta or grow that fetus. Maybe that made no sense to you at all, but I find that a helpful analogy when I'm explaining it to patients.
Hey Sarah, do you know what I've never asked you? Did you take a prenatal course when you were pregnant?
We did. Even though I'm a maternity care provider, my husband and I thought it would be an important process for us to go through together.
That's so cute. It must have been so hard for you guys to coordinate your busy schedules, though.
Oh, tell me about it. I was a medical resident at the time, and he was working full-time. We really struggled to find a course that would fit our needs and ended up doing a semi-private course that still was challenging to schedule and quite expensive.
Wouldn't it have been nice for you guys to have access to an online course with evidence-based content that you could do from the comfort of your own home or on your own time at your own pace?
You're telling me if I had had access to something like our Pregnancy to Parenthood prenatal masterclass, it would have been a game changer.
And that's the big reason we put this course together, to provide parents with access to reliable, comprehensive prenatal education from the comfort of their own homes and the ability to watch it and rewatch it when and where they choose.
Plus, it's got so much great information about preparing for the fourth trimester, which I'll admit, I felt really unprepared for. We focus so much on labor and birth when we're pregnant without understanding how challenging breastfeeding in the fourth trimester can be.
I hear ya. And that's why we put together such a comprehensive module all about what to expect for the fourth trimester and for your newborn.
If any of you listeners are pregnant and thinking about a prenatal course, I may be biased, but I would 100% recommend our online course. Head on over to www.shefoundhealth.ca/masterclass to check it out.
We promise you won't be disappointed or your money back.
So, do we know who's at risk of developing gestational hypertension or preeclampsia? There are a number of risk factors that we know do put people at an increased risk of developing preeclampsia. These can include a previous history. So someone who's previously had preeclampsia is 8 times more likely to develop it in a subsequent pregnancy. We know individuals who have underlying medical conditions like pre-existing diabetes or chronic hypertension are at higher risk. Some autoimmune disorders put people at an increased risk, as well as individuals with a pre-pregnancy BMI of greater than 25, as well as individuals with underlying chronic kidney disease. Now, it's important to understand that a multi-fetal pregnancy, so twins or triplets, increases your risk simply because you've got 2 placentas, so you're at twice the risk. Now, nulliparity or never having been pregnant before does increase the risk, and there's some thought that this is due to an immune system exposure to the paternal antigens. A family history of preeclampsia can also increase the risk, as well as a prior pregnancy with complications that can be associated with placental insufficiency, so a previous pregnancy complicated by growth restriction, abruption, or stillbirth. Advanced maternal age, so individuals over 35, and more so for individuals over 40, and the use of assisted reproductive technologies. We know this is a big list, so basically, there's a lot of things that put people at an increased risk for high blood pressure in pregnancy. So how do we diagnose it? Now that we know what these conditions are, we'll briefly chat about how we diagnose them. And this is a review of what we've already talked about, but we know this is complex stuff, so we wanted to recap. Your blood pressure is measured at each prenatal visit. If your blood pressure is found to be elevated with a systolic or top number over 140 and or a diastolic bottom number over 90, your provider will likely check your blood pressure several more times during that visit, and with an automated blood pressure cuff if available. There are also some clinical symptoms your provider will ask you about, as well as some physical exam findings that may help us figure out how significant the high blood pressure is. Symptoms such as visual disturbances, so typically seeing spots or stars, a new headache, chest pain, shortness of breath, pain in the upper right side of your abdomen, where your liver sits, and new swelling in the hands and feet can be, but isn't always associated with preeclampsia. Sometimes these are just symptoms of pregnancy. They'll also check your reflexes, so typically your patellar reflexes, and check your feet for something we call clonus. If you have preeclampsia, then typically the high blood pressure is causing some increased stress on your nervous system, which results in what we call hyperactive reflexes. Additionally, depending on how far into the pregnancy you are and how high your blood pressure is, they'll likely send you for some lab work that will help us to determine if it's gestational hypertension, so high blood pressure without any adverse or worrisome features, or if it's preeclampsia. Again, depending on how pregnant you are or how high your blood pressure is, they may simply ask you to go to an outpatient lab, or they may send you directly to the hospital to have your blood pressure checked at the hospital and have your baby checked as well. When we order blood work, we're looking for signs that your blood pressure is starting to cause damage to your organs, in particular your liver and your kidneys. We then take these 3 factors, your blood pressure, your physical exam, and your lab work, and decide where to go from there. Because we know it's ultimately caused by the placenta, we also need to evaluate the baby, and this is an indirect marker of how well the placenta is functioning. We can measure this by doing an ultrasound and assessing the baby's growth, the amount of amniotic fluid present, and how the blood is flowing through the umbilical cord. Management is complex and often specific to each individual depending on where they are in pregnancy, other underlying risk factors, and how well your baby's growing. We'll touch generally on the management and medications in general, which includes medication and fetal monitoring. So first up, let's talk about medications. Once your blood pressure is significantly and consistently elevated, generally top numbers over 150, 160, bottom numbers over 100 to 110, we'll initiate treatment. Now, this is a higher threshold in the non-pregnant population because there's a really fine balance of needing to keep enough pressure pushing blood through to the placenta, but keeping your blood pressures from not getting so high that it causes maternal damage. So the blood pressure target is typically anywhere between 130 over 150 systolic and between 80 to 100 diastolic. There are 2 medications that we routinely use that we know are safe in pregnancy. This includes labetalol, which is a beta blocker, and nifedipine, which is a calcium channel blocker. The medication we choose depends on a number of factors. Some individuals end up on one, while others require both medications. In addition to medication, we also need to monitor the fetus. Because we know it's associated with an abnormal placenta, it's important for us to monitor fetal growth and well-being. This is typically performed by growth ultrasounds to assess amniotic fluid levels and cord Dopplers. NSTs, so non-stress tests, are also routinely performed as these provide a good indication of fetal oxygenation, as well as it's recommended pregnant people be mindful of fetal movement counting. Now, although there's so much more we could talk about in terms of timing of delivery and additional medications we can offer for fetal well-being, we've already covered a ton in today's podcast. So we won't go into specific detail, but we will say that for most people with gestational hypertension or preeclampsia, induction of labor is often indicated when you start to have signs of placental insufficiency or the placenta not working as well. This includes low amniotic fluid, an abnormal non-stress test, or difficulty with the blood flowing through the cord. Worsening maternal lab values or worsening maternal symptoms is also an indication for delivery. So you might ask, well, is there anything I can do to prevent gestational hypertension or preeclampsia? The good news is the answer is yes, there is. For those with underlying health conditions that put you at an increased risk, and these include some of the risk factors we discussed above, we recommend starting on baby aspirin in the first trimester. Baby aspirin, you ask? Is that safe? I thought we weren't supposed to take NSAIDs, which stands for non-steroidal anti-inflammatory drugs, in pregnancy. And it absolutely is. Aspirin is the exception at low doses. Additionally, for those with pre-existing or chronic hypertension, making sure your blood pressure is well controlled coming into pregnancy and that you're on pregnancy-safe blood pressure medications is really important. And lastly, if you're trying to conceive and you're carrying extra weight, improving your diet and increasing physical activity will also reduce your risk of developing gestational hypertension and preeclampsia. So that's it. Pretty straightforward, isn't it? I'm just kidding. It's really complex. So basically, in a nutshell, there are 4 main types of hypertensive disorders in pregnancy: eclampsia and HELP syndrome, gestational hypertension, chronic hypertension, and then that one category where individuals who have chronic hypertension get preeclampsia superimposed on top of it. We identified individuals that might be at higher risk. We talked about treatment options and what you can do if you're planning a pregnancy and might have increased risk factors. We hope you found this helpful and not overly confusing. And now, if you are in the planning pregnancy stage, please go ahead and download our Preparing for Pregnancy guide, which we've attached in the show notes below. It's really important to do what you can to optimize your health before getting pregnant. Thanks for listening, and we'll chat with you soon.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.